for the invitation from both AIOC and APVRS to join today. So I very much enjoyed Dr. Atul's talk just now, highlighting many of the factors that we still haven't completely understood about pachychoroid, and maybe central serous is the most typical of the diseases within the pachychoroid spectrum, and of course, as Timothy's mentioned, in our population, PCV is another very common lesion. So if we go back to central serous, our understanding has again really evolved with the advances of imaging. We know that from early on, we mostly concentrated on what's happening above the RPE. We used mainly SA, and we looked for these RPE kind of punctures and leakages. And subsequently, using ICGA was then first highlighted that there was a lot of changes within these eyes. Particularly, we noted congestion of the large choroidal vessels. This is even very early on, before we relied on OCT, and definitely before OCTA came into clinical practice. And you can see in the late phase, there is choroidal hyperpermeability as well. And concurrently, we subsequently, this is paper back in 2009 using EDI OCT, noticed that in central serous choroidal retinopathy, they also have a thickened choroid, which goes hand in hand with that appearance we noted on ICGA. That led to our renaming of central serous retinopathy to central serous choroidal retinopathy, with the hypothesis now commonly accepted as choroid being the primary location of the disease, starting with choroidal hyperpermeability, and that pressure goes up one layer at a time through decompensation of the RPE and leading to neurosensory detachment eventually, and damaging the photoreceptor. Similar findings in the choroid have also been mentioned in PCV. This is again very early paper back in 2011, showing that thickened choroid was noted in PCV as much as they are seen in central serous choroidal retinopathy, and contrasting very much so to those eyes with typical AMD. So we now use a combination of thickness based on OCT, and together with ICGA showing not just thickness in the paper on the right, but also vascular hyperpermeability being some of the key features we see in this group of disease, which, as Dr. Atul said, now we group them as this name called pachychoroid, which I'm not sure is helpful or not, because that there is so much controversy with this name. So that's all relatively known. And in the next few minutes, I'd like to just highlight some of the newer studies. We know what are the descriptive features, as mentioned, but still we don't understand what led to these. And Dr. Atul mentioned the concept of choroidal congestion, which seems to be something that we're looking more and more towards. So first of all, using OCT and geography, it is great. We can look at these large choroidal vessels non-invasively, and we can look at, generally most papers highlight these changes within the macular region, as you can see in this example. However, there is a limit to the field of view, and we generally call these pachy vessels. We characterize them as deep choroidal vessels, increased caliber. Again, there is no threshold for calling what is big or small. They generally also, in terms of morphology, do not taper towards the posterior pole, which is where we expect the physiological watershed zone to be, and may terminate abruptly as well. So if we just examine the macular region, we can see this kind of image with ICG, or the one that I showed you just now with OCTA. Recently, we had the opportunity to look further out, and this is with wide field ICTA. We find that, of course, we see these vessels either next to a disc or in the macular region, but when we look further out, they seem to be linked to or connected to at least two or even more separate vortex systems. As you can see in this example, you can see anastomotic connections as highlighted here. There's another eye showing you several anastomotic connections, and this is another eye in the paper, which shows these connections are around the disc when it comes to peripapillary pachychoroid syndrome, and they tend to be more so in the macular region when it comes to central serous and PCV. Now, then, if these are anastomotic vessels, it is not purely a matter of temporary dilation because of chemical changes, etc. So what leads to these remodeling of these vessels? If we look back at the formation of collaterals, for example, in retinal vein occlusion, we know that there may be some pressure gradient defects. This just to highlight that similar findings have been noted, not using ICGA, but using OCT angiography, not so much in terms of wide field, but similar kind of concept. A lot of work has been done by the Japanese group led by Dr. Matsumoto and Akiyama as well. And recently there has been a very nice review by Ashish Sharma and co-authors as well. Just I'd like to highlight these if you're interested in this topic. So recently we looked at what's happening in terms of the filling within these dilated vessels by looking at the dynamic ICG. And in quite a few eyes, we find that you can see this kind of sluggish motion, almost like an RVO cattle tracking kind of appearance. This is, of course, happening in the large choroidal vessels. And these often can be seen to connect segments of proximal and distal dilated vessel segments as well. Here, in this case, you can see very clearly this blood column of blood is trying very hard to push its way from the left towards the right and eventually linking up the two segments. And when we look at the late still image, when the filling has completed, we'll say, yeah, this is a pachyvessel or anastomotic connection, but it is really the dynamic filling that tells us maybe this vessel formed because of some sort of congestion and outflow obstruction. And in fact, very interestingly, this kind of concept has been highlighted long ago. It's now with additional small pieces of the jigsaw puzzle that we are trying to put them together. This is very nice work done by Korean group back in 2013, suggesting that there may be outflow obstruction or congestion at the very least in the vortex system. So what is the implication? So we see these findings. I think for now, at least we've mentioned that in terms of treatment, we've noted that choroidal thickness comes down with PDT, with certain anti-VEGF, but not so if we are only doing thermal laser. And that seems to suggest that it may be good to have a reduction in that thickening or congestion within these choroidal vessels. And the question is, can we achieve that? And how could we achieve that? And this is another paper from Hong Kong group. Timothy was involved, showing with PDT, as you can see in the example on the right-hand side, that the permeability comes down on the ICG after half-dose PDT. We'll come back to this image in a moment. So what is important is that when we talk about the choroid, we've looked at various parameters. I've talked about the anastomotic vessels, which are the vessels themselves. And then I've talked about hyperpermeability, which is the diffusion of the dye and the exudation into the choroidal stroma. And another new piece of tool that may come into just the right time is the choroidal vascularity index, which has been, again, knocking around for the past 5 to 6 years. And it is basically binarizing the choroidal segment. And now, in addition to manually doing it in the subfoveal region, we are able to do a volumetric assessment. So you can have a CVI map automated as such. And we're using that in a beta version of the TopCon algorithm. And you can monitor the changes as this eye undergoes. It looks at treatment for PCV from baseline to month 3 to month 12. On the right-hand side, you can see that the choroidal thickness comes down, but also the choroidal vascularity index came down in this eye. Even if you eyeball that OCT on the left-hand side, you can see that the choroid is generally looking less dark with time. Now, when we plotted that against a cohort of 17 eyes, what's quite interesting is this is choroidal thickness in the y-axis, and the red dotted line shows you the no change from at month 12 to baseline line. And we find that by and large, most eyes showed a reduction in choroidal thickness, quite marked reduction, in fact, up to 20 to 30%. What happens to choroidal vascularity? So here is plotted in the x-axis, again, in the dotted line is the no change line. And we found a by and large, there was very little excursion, only about 4% changes either way. And not only that, with that marked reduction in thickness, we were quite surprised to find that some eyes, ironically, had an increase in choroidal vascularity index. So what does that mean? How can choroidal vascularity index increase as thickness decrease? Well, going back to the two components within the choroid, it will suggest that the dilated vessel lumen are still there because they are anastomotic segments. They don't just go away, they don't just close up. Maybe they are less congested. And looking at that example on the right from the Hong Kong paper, you can see that the vascular hyperpermeability gets better, but the dilated segments are still there. And concurrently, you can see a reduction in stromal congestion. And I would not be surprised if we apply the CVI in this eye, we show that the thickness comes down, but the CVI actually increases. So just in summary, we've highlighted some of the established choroidal features, and with newer imaging, we can maybe have a new kind of understanding to some of these features that we've described in terms of hyperpermeability. It may be due to choroidal outflow disturbance in terms of just the dilated hallux vessels. Now we hypothesize that these are not just dilated, but in fact anastomotic segments, and the increased thickness may be due to venous stasis and leakage. And ultimately, the CVI may be a new mechanism that we can study different components within the choroid. And the question that I will end is, would reduction in choroidal hyperpermeability, rather than looking for a reduction in the thickness, be something that would be an additional treatment endpoint that we want to look for in the future? So thank you very much for the opportunity for me to share with you these findings.